organization. Thank you for joining us today. I officially will call the meeting to order now and would request if we can get a proposal for approval of our minutes from the May 5th, 2025 meeting.
So moved.
Okay, thank you. And all in favor, Dr. Pagan?
Yes.
Dr. Spiritu, Dr. Katz?
Yes.
All right, that is now approved. Next, I would like to propose a motion to enter into executive session to discuss privileged and confidential information. If I could have a second.
Second.
Okay, all approve?
Yes.
Okay, any opposed? Thank you. Okay, for those of you who know we're in session, we're going to the next room for executive session, and we will be back shortly. I hear you. But we probably might still want to hear that. Thank you all for your patience, much appreciated. We will again commence with our meeting and begin, if Kenner, if you would mind to discuss the Patron resolution, if you can read it to me and.
Good morning, Dr. Calamina, committee members. My name is Kendra Ford, Senior Vice President, Clinical Services Operations. I'm going to read the resolution, and then I'd like to invite Dr. Steve Pulitzer to provide the overview. Authorizing the New York City Health and Hospitals Corporation, the system, to execute a contract with Patron Associates, LLC, for medical physics consulting services and radiation safety services at a not-to-exceed amount of $14 million, which includes a 30% contingency for a contract term of 3 years, 2 renewal options exercisable at the discretion of the system. Dr. Pulitzer.
Good morning. Thank you for having us today. So over the past 10 years, New York City Health and Hospitals has transitioned from an in-house medical physicist at each of our acute sites to a third-party medical physicist vendor contract. The benefits of this transition include the ability to provide medical services at all clinical sites, improved accuracy of record keeping for necessary accreditation, improved quality of medical physicist services across all sites, increased scope of radiation services at all sites, and the ability to rapidly expand services as needed if we're adding new equipment or new modalities. New York City Health and Hospitals facilities that operate imaging equipment currently retain Patron Associates, and they perform radiation and performance testing, provide on-site support, provide regular updates in anticipation of standard and regulatory changes, and provide education for our non-radiologists in order for them to provide fluoroscopy and other issues, other imaging studies across the system. Patron Associates has been providing these services to New York City Health and Hospitals since 2010. Patron Associates was procured through a competitive RFP, and contract award was approved by the CRC in May of 2020, by the board in June of 2020, at a not-to-exceed amount of $8.8 million. The current contract expires August 17th, 2025, and the current contract spend is $9.1 million. The contract overspend was due to requests for medical physicist services and additional non-acute facilities as a result of internal staffing changes, COVID-19 related services such as Billie Jean King Stadium, introduction of new modalities at new sites, and a need to expand radiation safety officer responsibilities. The result of the new procurement will allow for additional equipment to be added to the fleet, new system imaging centers to go online, new radiation safety needs, and the cost of the contract will increase with the increase of those services. Just a review of what we did for this RFP was we set a minimum criteria. We had an evaluation committee that were senior leaders at sites. They were radiology chiefs of service and radiology senior level directors. And then the process began in January of 2025. The application to issue a request for proposals was approved by the CRC. In March of 2025, the RFP was posted on the city record and sent directly to 3 vendors. Later that month, the pre-proposal conference was held and 1 vendor attended. 4/1/2025, the proposals were due. 1 proposal was received. And on 4/9, the evaluation committee submitted final scores. The top scoring was Patron Associates. For the other 2 vendors, the 1 vendor did not respond to our request, and the other vendor was not able to meet our on-site needs. The vendor diversity team reviewed the scope of work and determined that there were no subcontracting opportunities under the solicitation. So again, we are asking the Medical and Professional Affairs Information Technology Committee to authorize New York City Health and Hospitals Corporation to execute a contract with Patron Associates, LLC, for medical physics consulting services and radiation safety services at a not-to-exceed amount of $14 million, which includes a 30% contingency for a contract term of 3 years and 2 renewal options exercisable at the discretion of the system. Thank you very much.
Thank you. Questions? One question I would ask, contingency fees, contingencies that are unexpected, it's 30%. Was there a sense that maybe there are going to be more services that we aren't anticipating now, or what was the reason for it to be that number?
Yes. So we have new equipment going in that requires like a number of new MRIs that will be added to the system, PET scanners added to the system, and new sites added to the system. So all of those together, we feel will raise it to approximately 30% of what the initial contract is asking.
Okay, so it's a contingency, but the reality is it's an expectation that we're probably going to be having, if all goes well, the added
Exactly.
services.
A lot of that is in motion already.
Right. And just the usual process for approval above the, it would just stay internally with radiology, or who actually would end up, as we do these additional services, taking on, or I guess paying the extra dollars in the contingency? Is that just sort of based on need, or who makes that final decision?
If the contingency will be approved,
No, no, if after we've reached, the number that we say is our maximum, whatever, and we now have to go into our contingency.
Well, remember, we budget, which the board sees, right? We budget at any time for the services that we're providing. I think what we're anticipating is, in this case, we will likely provide more services than we currently have. Anytime we increase services, we can only do it if we have the revenue. So the way it would happen is we would open a new site or have an additional piece of equipment. We'd say, okay, well, how much revenue we're going to produce, and does that revenue cover it? And we've talked about this in other forums. Ultimately, because the board sees on a quarterly basis our expenditures, right? That's why we want to go to more of a process of having percent contingencies, because what you're approving is you're approving the manner of how we acquire these services. We acquire these services from this provider, in this way, right? What really then matters from the fiduciary responsibility is that we always match our expenses and our revenues, and that the board sees, and trying to get away from trying to manage the expenditures of one specific contract if the contract grows because of increases in volume, right? And so nothing is really changing, we're just doing more of it. We want to focus the board's attention on its fiduciary role in matching expenses to revenues, because that's what we do, right? I would never allow the opening of a new machine if I didn't believe that we had the money to do it, because, right, there's no other source, right? There's no other way we would do it, and if someone actually did it, you would see it in the quarterly report, because you would see all of a sudden, gee, the expenses now exceed the revenue. What are you going to do? We are a cash business. We cannot run expenses above revenue. We have no endowment. It always has to match. So, that we want to be going forward, in volume-related contracts, allowing for the continued growth of health and hospitals. And again, I think we've discussed it in other forms. The other major change is health and hospitals was an organization shrinking. And when you're an organization shrinking, your contingency is not so important, except maybe construction, where you never know what's behind the next wall. We are now an organization growing. And it makes sense to allow for, as long as we are following the terms of a contract and just doing it in the board-approved way, to track the expenses and revenues on the quarterly financial reports.
Yeah, I totally think that makes enormous good sense, and I don't think the board wants to be involved in wondering, about small changes there. I guess my question was more, as you expand these services, where's the ultimate responsibility for saying, yeah, we want to do this, we want to do that? Where does that end? Not so much the financial piece.
Finance. Ultimately, it's the CFO.
Well, I'm thinking more the
controller.
clinical piece. In other words, we want to open this center. That's all going through radiology, basically?
It would,
Is that what-
no, it would go through me and through
Okay,
the senior
that's what I
vice.
was really
The
trying.
senior vice presidents would make the decisions, but among one of the controls is that if I made a decision and the finance people were like, Mitch, you don't have the money to do this, right? It would essentially get blocked because, right, they have also a fiduciary responsibility to make sure we don't spend more than the city has given us or that we can get through revenue. So, but yes, the policy decision would be made by the SVPs.
Perfect. That's really what I was trying to get at. That's perfect. Okay, super. Other questions? Okay, there being none, let's go to a vote then. Dr. Pagan?
Yes.
Yes. Dr. Spiritu?
Yes.
Dr. Katz?
Yes.
I'm also a yes. So motion carries. Thank you so much. Appreciate it.
Thank you very much.
All right. And Patsy, we're up next. Dr. Yang? Welcome.
Morning. Patsy Yang, Senior Vice President of Professional Health Services, and I'm here with Tim O'Leary, our Chief Financial Officer, who's going to take you through the.
Yeah, good morning. Here's the resolution authorizing New York City Health and Hospitals Corporation, the system, to negotiate and execute an agreement with Correctional Dental Associates, CDA, for the continued provision of dental health services for its correctional health patients, CHS patients, for 3 years, starting January 1, 2026, for an amount not to exceed $42,266,557, which includes an option to renew for 3 additional one-year terms and a 20% contingency. So some background here, CHS is responsible for the provision of health services, including dental services, to all individuals in New York City jail system. Dental services for all patients in CHS care are mandated by the New York State Commission of Correction, New York City Board of Correction, New York correctional laws, as well as some regulations for the Department of Health. Dental staff employed by dental vendors must meet specific recruitment and onboarding criteria, such as graduating from an approved accredited school of dentistry, successful completion of a residency program, valid certification from the American Board of General Dentistry, and security clearance and credentialing by the Department of Correction, as well as New York City Health and Hospitals. Here's some background on the current contract. H&H entered into an agreement with CDA for dental services starting in 2016 and at the end of 2019. This resolution was approved by the board for a not to exceed of $13.4 million. The contract included 3 renewal options, each for 2-year terms, and the system approved those options for a total of 6 years. The expenditures for CDA during the life of the 2019 to 2025 contract averaged about $4.6 million for a total of $28 million. CHS receives monthly reporting of time and time records for work performed by CDA and reimburses for direct costs, salaries, fringe, and some administrative expenses. And as always, CHS is fully funded by an MOU with New York City for the costs of this contract, as well as all expenses for CHS. Here's an overview of the RFP. We conducted an RFP to assess the market, ensure the system securing the best interests. It included employing certified and licensed professionals, including dentists, oral surgeons, hygienists, dental assistants, and admin staff. The request was to staff multiple clinics 5 to 6 days a week at CHS facilities on Rikers Island, and soon the OTXHUs, depending on the need. Varies generally between 20 to 25 FTEs, depending on the patient profile at the time. This required providing preventative dental care, including cleaning, dentistry, oral surgery, consultations, and referrals, and to provide monthly reporting of expenditures. Here's the criteria we used. We had some minimum criteria, including experience in correctional health settings, as the substantive criteria is laid out there. And we had 7 members of the evaluation committee, 5 of which were CHS executives, and 2 were folks from partner hospitals that had significant dental experience. Overview of the timeline. In December, we received approval by the CRC to issue the RFP. January, the RFP was posted. February, proposals were due, 4 came back. And in April, the evaluation committee submitted the scores and picked CDA as the top scorer. Here is the vendor performance. They were rated excellent. Vendor diversity, Correctional Dental Associates is a New York State certified minority business enterprise. And again, for your consideration, authorizing New York City Health and Hospitals Corporation, the system, to negotiate and execute an agreement with Correctional Dental Associates, CDA, for the continued provision of dental health services for its correctional health patients, CHS patients, for 3 years, starting January 1, 2026, for an amount not to exceed $42,266,557, which includes an option to renew for 3 additional 1-year terms and a 20% contingency.
Thank you. Questions? I guess my only question would be related to obviously it's an increase in the amount of monies over the previous budget. I'm just curious about, is some of that unit cost, or is it related to the types of services or the number of services or locations? Has anything changed there, or how is that?
So we are assuming the same scope of work that we have now. The contingency is for unforeseen circumstances as well. It just increases in patients if we see that, as well as several sites we're going to have in the future, the OTXHUs. The increasing in cost is just related to annual growth at about 3 to 3.4%. So no change there besides
Okay,
that.
so services are pretty much the same. It's more the incremental cost of performing the service.
Yes.
Other questions? All right, let's go to a vote then. Dr. Pagan?
Yes.
Dr. Espiritu? Dr. Katz?
Yes.
Yes as well. Motion carries. Thank you. Patsy, you had the next one as well, so.
Tim's going to do that too. It's for our urgent medical PC.
The request is authorizing New York City Health and Hospitals Corporation, the system, to negotiate and execute a best interest renewal with Urgent Medical PC for continued provision of emergency medical triaging services for correctional health patients, CHS patients, for a 6-year term running from January 1, 2026 through December 31, 2031, for an amount not to exceed $17,914,184, which includes a 20% contingency. Again, CHS is responsible for all provision of health services in New York City jails. CHS requires a vendor to provide continuous and constant support by board-certified emergency medical physicians for on-site emergency medical response, urgent and emergency consultation, triaging, and emergency room referrals at all times, 24/7, 365. Services include in-person immediate response to all emergency medical situations anywhere within New York City jails, provision of emergency medical supervision of overall care, provision of telephonic or tele-video consultations, provision of emergency and urgent medical guidance and technical assistance to CHS, and to monitor and evaluate all emergency activities for timeliness, quality, and appropriateness as part of CHS's overall quality management process. The background for the existing contract: Health and Hospitals entered into an agreement with UrgiCare, subsequently named Urgent Medical, for a term starting in 2016, ending in 2019 with no renewal options. A resolution was approved by the board for a not to exceed of $1.8 million per year, with annual increases up to 6%. In December 2019, the system approved a new agreement with Urgent Medical for 6 years, which ends at the end of this calendar year, and there are no new renewal options. The agreement operated with a not to exceed of $2 million in the first year, with an allowed increase of 2% year over year. And total expenditures during that period, that 6-year contract, are $12.8 million. And as always, CHS is fully funded by the MOU in New York City for the cost of this contract. Under operating procedure 100-05, the system can renew a contract with appropriate vendor and pricing due diligence rather than re-procure. We believe it's in the system's best interest to do so in this time. The vendor is a critical component of CHS's clinical infrastructure. The vendor was rated excellent in an annual vendor accountability review. CHS Finance reviewed the market and found no other suitable vendors with comparable experience. We also reviewed the possibility of insourcing and found that would lead to a significant increase in direct and indirect costs. And CHS is going to be adding biweekly reporting of expenses performed under this contract to ensure that the money expended are fully reimbursed. To conclude, we believe this will provide stability in patient care, and the vendor has a unique and extensive experience in emergency situations in New York City facilities. This contract will be a 6-year contract with an anticipated start date of 2026. Start of 2026. The NTE is $17.9 million. This contingency will allow us to be better positioned to be able to respond in the event of unforeseen circumstances. And the anticipated spend in the first year is $2.3 million. This will be a renewal of the existing scope that we went through. The vendor was rated excellent. The vendor diversity unit has analyzed the availability of MWBEs to perform the work required under this solicitation and have not found any. And again, the authorization for your consideration, authorizing New York City Health and Hospitals Corporation, the system, to negotiate and execute a best interest renewal agreement with Urgent Medical PC for the continued provision of emergency medical triaging services for correctional health patients, CHS patients, for a 6-year term running from January 1, 2026 through December 31, 2031 for an amount not to exceed $17,914,184, which includes a 20% contingency.
Thank you. Questions? All right, no questions. Time for a vote. Dr. Spiritu?
Yes.
Pagan? Dr. Katz?
Yes.
Myself, yes. Motion carries. Thank you so much. Appreciate it. All right. Kenry, you're up again.
Item,
I have to recuse myself from this resolution?
yeah. No, but I wanted to make sure I was on the correct item. Item number 4, or resolution number 4, authorizing New York City Health and Hospitals Corporation, the system, to execute affiliation agreements. The affiliation agreements with NYU Grossman School of Medicine, NYU, for the provision of general health care and behavioral health services at New York City Health and Hospitals Bellevue, New York City Health and Hospitals Gotham Health, Gouverneur, New York City Health and Hospitals Kohler Rehabilitation and Nursing Care Center, and New York City Health and Hospitals Henry J. Carter Specialty Hospital and Nursing Facility, and New York City Health and Hospitals Woodhall, New York City Health and Hospitals Gotham Health, Cumberland. Such affiliation agreements will run through June 30th, 2030 for an amount not to exceed $4,446,524,858, which includes a 10% contingency. Dr. Tekke.
Good morning. I am Dr. Sweet Tekke. I'm a radiation oncologist here at New York City Health and Hospitals and the System Chief for Clinical Affairs. I'll be presenting this agreement request today. So as a reminder, New York City Health and Hospitals contracts with multiple affiliates to staff our facilities with medical providers. And we staff approximately 6,000 FTEs this way, including over 3,000 physician FTEs. About 1,600 of those are allocated to NYU sites, which are the ones we'll be focused on today. Next slide. So a review of our affiliate agreements with NYU Grossman School of Medicine. NYU has been our partner for many years, and just to summarize this slide, if you can go through to the last bullet, these are primarily cost-based arrangements, which include compensation, fringe, and overhead. And I do want to focus on the fact that our NYU affiliate, and specifically Bellevue, is the only quaternary hospital in our center, in our system, so it provides really advanced level care to all New Yorkers at these sites. Next slide. Over the time period that the last contract has been in place, which is fiscal year 21 to fiscal year 24, we've seen a 10% growth in FTEs employed under the NYU affiliate. And this is actually far outpaced by the volume growth at the affiliate during that time. So we've had significant growth in inpatient volume as well as outpatient volume. And if we were to zero in a little bit on the provider growth, it's really been focused primarily on advanced practice providers who we needed to really staff this growth in inpatient and outpatient volume, and they've been providing really excellent level of care at those sites. Next slide. And this is a snapshot for fiscal year 24, where we have the most recent complete data, just showing the number of FTEs, the physicians, APPs, and other staff employed under this agreement, and focusing on the fact that NYU is our second largest affiliate employer. In addition, we have multiple GME programs that are run through our NYU affiliate that we partner with them very closely on, and these are the largest programs at H&H. Bellevue has 450 FTE trainees, and Woodhall has 134, representing multiple programs and very advanced care. Next slide. So thinking about how we went into this agreement and what we are reflecting on with the prior agreement. So we've had multiple accomplishments over the past term of the contract, and we want to really build on that for ongoing work for this fiscal year and beyond. So we had 3 priority domains for improvement. Number 1, governance and management. Number 2, financial. And number 3, clinical services and operations. We've achieved major goals of stabilizing and professionalizing this affiliate agreement and how we manage our provider staff at this affiliate. And we want to continue to build on that. Next slide. So maybe just focusing on some highlights. Governance and management. In the past 4 years, what we've done, we've really improved transparency and our H&H management of the affiliate agreement. We've had more oversight into what's happening with hiring, more oversight into the budgeting and budget management. Our facility CEOs are more involved in the hiring and the decision-making on the ground, which has been really nice for them to have some flexibility while still being in close communication with us about their needs. Next slide. For this year and onwards, we want to really increasingly actively manage the hiring, budgeting, and contract terms with our NYU affiliate sites. So we want to maintain clear and enforceable contract terms that remain flexible to innovation and changing care needs. And we want to strengthen the operational and financial reporting transparency. We've made a lot of progress. We're pretty much almost there, but we want to continue to build on this progress and have that very close, tight communication with our CEOs and our affiliate. Next slide. Next domain is financial. So focusing on what we've done over the past 4 years. We've incorporated affiliate budgeting into the system's strategic and financial operations. As you can tell, these are big contracts, so we really have to watch them closely and make sure that they're providing the value that we need. So prior to this, the last contract, there were some areas for improvement that have really been addressed. We've aligned financial incentives with the affiliates and the physicians. We drove culture change by thinking of the budget as revenue-generating investments. Really, our staff are generating revenue, and that is really important for our financial sustainability. We've developed incentive payments via faculty practice plans at Woodhull, which has just been implemented a year ago, and Bellevue, which was implemented in the last fiscal year. And we've also invested in base compensation across core specialties to really stabilize the staffing at our sites and to compete in the market. And then lastly, we've recently come to an agreement with Doctors' Council and implemented significant cost of living adjustments that we believe will also significantly help with recruitment and retention. Next slide. Going forward, our goals for this contract are to continue to drive performance improvement for efficiency, recruitment, and strategic revenue goals. We are going to be fully implementing the FPPs to really align the physician incentives with our strategic goals. And we are continuing to ensure that the compensation and benefit packages are competitive, but also working within our resources. Next slide. The last strategic domain, clinical services and operations. Over the last 4 years, we've moved from more of an ad hoc clinical service development to multi-year workforce planning. So really engaging our facility leadership and our affiliate leadership to think about how we want to build the workforce for the future at their sites. And our key accomplishments are that we've implemented staffing models in multiple strategic and key clinical areas, including emergency medicine, behavioral health, primary care, hematology, oncology. And this has helped stabilize those services and also drive growth, because if you have a stable service, you can see more patients. Next slide. For fiscal year 26 onwards, we want to incorporate the NYU affiliate into our proactive system-wide workforce planning, so moving beyond just the facility level workforce planning to our system needs. We're going to continue partnering with them on shared services. That has been a point that we have discussed with them and continue to work with them on. And we are continuing to establish attractive career opportunities for the next generation of providers that really meets their goals while meeting our goals. Next slide. We do want to highlight that revenue growth has exceeded the contract costs in the last 4 years. So the NYU affiliate sites have grown revenue significantly, and that has outpaced the absolute increase in the contract cost, the expense of hiring our doctors. So really, as we're working towards thinking of our services as revenue generating, we are achieving that goal, and we will continue to build on that. And our projected growth rate over the next 5 years, we believe, will be slower than it has been in the last several years due to the progress we've achieved in in setting market standard salaries and more predictable growth in budgeting. So we've built in all the known adjustments to provider compensation that was agreed upon with our Doctors Council partners, and that's all incorporated here. So to summarize, the request is authorizing New York City Health and Hospitals Corporation, the system, to execute affiliation agreements with NYU Grossman School of Medicine for the provision of general healthcare and services at these sites listed. I won't rename them all. The total not to exceed value is $4,446,524,858 for the next 5 years, with a 10% contingency included. Thank you.
Thank you. It's a great presentation and really helpful to contrast with the previous contract and where you've come since then and some of the services. So I think that's very, very impressive. And obviously, I'm sure you're going to continue to monitor carefully and see how well we can continue to coordinate these services. But much appreciated. Questions or comments anyone else have? Okay. Dr. Cass, did you have anything to say?
No questions.
All right, time for a vote then. Dr. Spiritu, Dr. Katz,
Yes.
and myself, yes. Motion carries. Thank you very much. Appreciate it. Just gonna wait for Dr. Pagan to come back. All right, thank you. All right, we'll now consider an action item. Ms. Lipsyanskaya is going to present actually related to the neurosurgery at Brooklyn. So,
Thank you. I'm Svetlana Lipanska, CEO of South Brooklyn Health. I'm here with,
Philip Wadley, Associate Executive Director at South Brooklyn Health.
okay, and so here's the resolution authorizing New York City Health and Hospitals Corporation to execute a clinical services contract with Neurosurgery of Brooklyn South PC, the provider group, to provide neurosurgical services at New York City Health and Hospitals South Brooklyn Health for a contract amount of $19,403,000 with a 20% contingency of $3.880600 to bring the total cost of not to exceed to $23,283,600 for an initial term of 3 years with 2 one-year options to extend. Next slide, please. So a little bit of a background. South Brooklyn Health has been providing neurosurgical services at our locations for many, many years. We have been doing that through a subcontract with PAGNI. This is a transition of those services from a PAGNI contract to a direct health and hospitals contract. We will maintain the majority of the same providers. These are all providers in good standing that continue to receive performance evaluations as they have in the past. They are very good citizens of our provider community and have been doing excellent work. Next slide, please. I covered some of this. The reason to transition the contract. So we have already been functioning in this contract model. The reason that we're suggesting the movement from PAGNI to Health and Hospitals is that A, it gives us direct oversight over the contract and the providers. It allows us to save a little bit of money in paying for a 3% administration fee that we're paying to PAGNI. It also allows us to put in new quality indicators and quality KPIs into the contract, and to transition the Part B billing to Health and Hospitals. In the long term, this will have a fairly small effect on PAGNI. It is not huge dollars, but it is a very meaningful transition of leadership for us. PAGNI is aware of this shift, and we have been in discussions with them So therefore, time is a bit of the essence. We are very concerned about having any interruption in service. These are critical services that have to be available when they're needed, because a lot of this is to cover what comes in through our emergency department. So it's not something that we can necessarily predict exactly when the moment's going to be when we need this. By contracting directly for these clinical services, the system will retain the professional billing revenue. We will increase the control over the services and eliminate some administrative fees. We will also actually expand the amount of service. So we are going to be able to get more access for a relatively similar cost. And just to make sure that everybody understands, these are dollars that we're already spending. We're spending them as part of our PAGNI contract, and now we're going to be transitioning them back to health and hospitals to cover the cost directly. Next slide, please. The contract would be a direct systems contract. This is what we would get for it, 24/7 coverage, outpatient sessions, so 5 sessions a week of outpatient neurosurgery clinic, 5 OR days, for a base contract of $3,880,600 with a contingency. The total not to exceed will be $23,283,600. Next slide, please. Here's the resolution again, and I'm happy to answer any questions.
Thank you so much. Just curious with the KPIs incentive, is that something that's currently going on, or is that something that'll be now, something new and additional?
So the PAGNI contract did not have a KPI incentive, the KPI quality incentive. Our contract will have an incentive that is purely based on quality.
So it sounds like there are going to be a lot of advantages to having this more direct control for sure.
Yes, it is. I think this is, and frankly, very much in our interest to do. It makes it very clear what the relationship is between the department and department leadership, our CMO, our CQO, and these providers. So where we think that this will be a very good thing going forward. And these are all providers that are known to us, have been functioning in our system, have been doing very well, and have been providing very good service.
I mean, I think that's so critical. Neurosurgery, obviously, everyone knows, are really, you know, it's a very specialty, and the fact that you have a track record and these are the same people, I think is extraordinarily important. So I think that makes tremendous sense. Questions? Anyone else have?
I would just underline, it makes no sense to me why we would do this via PAGNI, right? I mean, PAGNI is a valued partner for hiring physicians. We don't need them to carry contracts. We have perfect capability of carrying contracts, and it actually increases the board's awareness and surveillance, right? Because if it goes via PAGNI, it would just be one line in a PAGNI affiliation agreement, right? So when we bring any contract to you through here, the board really has, you know, full insight into what the contract is and what the amounts are. If it's a line item on a PAGNI affiliation agreement, right, you're just approving a dollar amount for contractual services. So I think this is just not only better finance, it's better governance. It just makes much more sense.
I tend to agree. Any other questions, comments? Anyone else? All right, let's go to a vote then.
Yes.
That's yes on. Dr. Espiritu, I'm a yes as well. Congratulations. Keep up. Thank you. Fabulous work you guys do. Thank you. Okay. All right. We do have some time for some of our reports, so I don't know if anyone's here from MetroPlus.
Yes.
Oh, I didn't even see. So sorry. Most important person is here. Thank you.
Hang on those screens.
Do we have a? Sorry. All right.
time do I have?
We have some time, but try to keep it as brief as possible. We definitely want to have IT in as well. The other reports are going to be, they're already written reports, so nursing will not be. And Cameron will have a little, maybe a little time at the very end, very brief for you as well. So excellent. All right.
Okay. Um, So I would like to start with some good news on Health and Hospitals performance, quality performance. You can see, next slide, please. You can see on the first slide of my presentation that when we're looking at the quality performance on the VBP metrics, that there has been an improvement of 21% on the quality metrics, and then the dollars earned that in accordance with this improvement. H&H increased the points in its quality performance on all products, and of note for HIV SNP, in which we are just one of 3 plans that exist in New York State. H&H actually achieved 100% of the points, which is really remarkable.
Amazing.
Yes, absolutely. And you can see that 90% of the metrics actually improved from year to year. Again, an unbelievable performance. And just to put it in context, it's not just that H&H has improved in its quality from one year to the next. When we compare H&H's performance to the community provider performance, in nearly 70% of the measures, H&H outperforms the community. So I will not go into details. There are some details on the specific measures and how H&H has done, and what are some of the kind of secret sauces. There are many to the success. What I will say is it's not a fluke. It takes dedication, it takes resources, and it takes consistency. And this is exactly what we are seeing, both on the facility side, but also through central office under Matt Ziegler and his group. There is dedicated effort to make sure that we continue to progress on the quality metrics, and frankly, both on the medical side and the behavioral health side as well. So really great news, and we're very proud to share that. I'm going to go to the next topic and give a quick update on the topic that has been in the news quite a bit. And this is in regard to the transfer of the consumer-directed services, CDPAP, from 600 different financial intermediaries to one, named PPL. So the transition happened in April 1st, and it's still ongoing. Just because there's so much in the news and legal news, I just wanted to bring to the committee's attention the efforts that the plans have been putting into this transition, supporting it, and specifically what we have been doing. So some of the efforts from our plan is obviously notifying the members about the transition through every possible media channel that is available to us. We also helped directly the members to register on the new platform. And at some point, we have seen transition of the members, but not the transition of their personal assistants. And PPL is more of an administrative financial entity. They do not come with a pool of personal assistants. So it was critical not just to transition the members into PPL, but also assist the assistants to transition into PPL. So we did focus initially on the members, but then we saw that there was a significant lag with the personal assistants. So we started actually working with the personal assistants and helping them transition as well. So you can see there are thousands of letters and text messages and calls and home visits. That's essentially what it took. We prioritized initially the members with the highest hours because obviously they were at the highest risk, and very, very quickly we got to over 97%. So stratification is everything when you have masses and things are not necessarily progressing as expected with the transition. So, and the reason we got to almost 97% very quickly with the highest risk is because we deployed our care management staff into the homes. So we sent care managers with our transportation to knock on doors and make sure that people understand that this is happening. They have to take action. It's not just happening automatically. And we kind of held their hands until the transition actually happened. We continue to see some delay with the personal assistance, and while PPL was holding citywide kind of gatherings to help personal assistants to move, we still saw a significant gap. So we opened our own community offices. MetroPlus has 8 different community offices in the different boroughs. We opened our own community offices to bring the personal assistants so they can sign up on our computers with our staff into the PPL system. So all of that, ultimately, I'll just jump to the numbers. And these are already outdated, but out of the 3,500 members that were eligible for this transition, it's both from the long-term care and also from Medicaid. At this point, we're higher than 91. We're at 93% successfully transferred. 7% moved to an agency and chose not to continue with PCS. And at this point, it says 3% are still in progress, but we're talking about 61 members as of this morning. So a lot of effort, a lot of back and forth, a lot of pivoting, just to make sure that those individuals who we in general consider as higher risk, even if their hours are lower, get the services that they need. There's a brief presentation here on cybersecurity. Obviously, this is an ongoing issue. I just want to highlight 2 things here. One is when we had our third-party assessment around our cybersecurity risks, one of the risks that was identified was that we were connected to health and hospitals. So if there were a breach, it potentially could impact the other party as well, both ways. Breach from H&H going to MetroPlus, and the breach from MetroPlus going to H&H. This was identified as a risk, and so we are in the process of segmenting and separating the 2 systems. We're actually almost done in doing so. Kim and her team played a huge role in this segmentation, and I think we all know every day there are new ways to hack into the system. So the fact that we are isolating the risk and separating the 2 systems, so if God forbid there is a breach, it's contained, is a great step that both was identified by a third party and by us, and we're almost completing that segmentation. I just want to direct your attention to the last page on the cybersecurity presentation, just to show you that MetroPlus has been doing phenomenally well. We are constantly at an advanced performance. So the top score you can ever get, and this is objective third-party gold standard, is 800. We are at 770. Not only that we have been maintaining this for many years now, we had no meaningful dips, but we're also doing better than all of our competition. And then the last thing I will mention in my report is just to reemphasize how embedded we are in the community. You just have a very brief snapshot here of the many, over 500 different community events that we are doing. Obviously, part of it is to advance our business. We are in a very competitive business. There are many other plans who are courting the same populations we are, but also because of who we are and what we believe in our affiliation with health and hospitals. And so a lot of it is also just being embedded in the community, understanding the community, obviously it serves us well, but it's mostly doing the right thing, supporting the community, and then the community comes back and wants to be part of our business. And that concludes my brief report.
Just a quick question. Being able to isolate the two systems, do you see any issue, either of you, with respect to communication, important issues?
We've actually been working on that component. I think the most pressing issue was really around HR and but we share an Active Directory, and just as our staff come in through VPN, the virtual private network, the Metro Plus stuff will come in through VPN as well.
Super. Any other questions? Otherwise, we'll jump on. Kim, you can continue actually and tell us
Okay.
what's going on on IT end.
All right. Well, I will just highlight two small areas. One, not so small, actually, is about artificial intelligence. And we now have a vice president, Divya Pathak, who is over our chief digital data and AI chief. She has really done a phenomenal job. We've just recently launched our AI enablement strategy, and major components will ensure that we have a good foundation, as well as we have the essential building blocks in place. We have started with a governance platform that is in place, as well as we have presented a proposal for budget and have a first-year budget proposal. We are aligning all of we use the word demands, which is requests, for AI software and other functionality. We have now built that into our ServiceNow platform, which pulls everything together. It ensures that we have the budget, the security around it, and that it is prioritized based on strategic initiatives from the enterprise. So we are moving well in that area, and we'll provide you some updates as we continue to move forward. The other area, which I would love to show my graph, but it's in your paper, is our unprint initiative, and it's exactly what it says: try not to print, right? And so we made our initial, I think it's on, I don't know, you can see the page. We're at second quarter. We are up to date with where our goals were with our unprint initiative. We began with an awareness campaign, started here at central office, and I'll give you just some up-to-date stats here. It's probably towards the very last of your presentation there. We are focused on both black and white and color, as well as just the overall volume of printing. So when we first started, we were around 13.22 million. We are now down to 10.57 million. And that's overall. And we need to just keep in mind that we focused on central office, but that is for the enterprise. The next two graphs do focus on central office, where the overall volume, we started at 855K, now we're at 474K. As well as you can see the precipitous decline in color printing, as well as the black and white volume. Then we moved out to our facilities and we started with the administrative offices and the C-suites, looking for a champion there. And you can see, I thought it was kind of funny a little bit, that when you look at the decline in the color volume from 42K to 23, but the black and white volume went up a little bit. So we were still printing, but then look at the far right corner, you can see the overall volume actually did decline a little bit to 62K. So we will continue. This is a 5-year program to provide updates on that, and we can also align cost with that in the future as well, cost savings.
One of the things I love about this is, this started at a board meeting where Kim presented the overall cost to health and hospital of printing, and I was horrified. I'm like, how can an organization that is focused on the care of low-income people spend so much money on printing? Right, and so I gave her that challenge, and it's just amazing, right, how much, and obviously it's not just saving of money, it's an environmentally sound thing. Those color dyes are terrible for the environment. So Kim has really taken that challenge way more than I think anyone believed would be possible in terms of saving money in the environment.
Thank you, and the rest is submitted.
Fabulous. Excellent. We have 2 minutes actually for you, Henry, if you have anything special to say.
Dr. Moskovitz, can you do high-level 2 minutes, come quickly, in our division, under the leadership of Dr. Dave Silvestri, Dr. Moskovitz has been leading some significant efforts in utilization management and reducing denials. So just if you can take your snippets and the rest can be read, that would be terrific. We're certainly not giving you enough credit, but you'll read it in writing. Go ahead.
Thank you. So Josh Moskovitz, I'm an emergency physician, and I'm here as the Assistant Medical Director for Utilization Management and Clinical Service Operations. I guess the two high-level components I'd say to remember is our job is to help translate the great care we're providing into the medical record to make sure the insurers pay us for the service we're providing to keep us fiscally responsible. And in the last 2 years, we've saved about $100 million in denial management through our services here. And that's really the big picture. We really focus on the acute, unscheduled care arena where patients don't anticipate a medical emergency. They show up in our emergency department. We see them, provide care, admit them, and then making sure we're paid for our services. And so a lot of activities. I'd love to take more time if I had another opportunity, but $100 million in savings through our work as utilization management.
And the board has seen this in the finance report, right, that we continue to post year after year major increases in insurance revenue. And it's all because of efforts like what Josh is explaining.
Oh, it's fabulous work. Just curious how much the IT system has helped prompt as far as the initial contacts, and are there promptings to make sure that the proper information is there when it's evaluated by the insurance company?
Yeah, I mean, I could take an hour of your time doing this stuff, but essentially
Could
we
you
try
do it
every
in
opportunity to
40
nudge
seconds?
physicians. We try to nudge physicians to do the right choices documentation-wise, because we're all taught the medical decision-making, the medical treatment plans, and not how to necessarily navigate the insurance waters. And so we work very closely with IT to nudge physicians to gain the right details on the chart to make sure we're successful.
Gotcha. Excellent. Any other questions or comments? Obviously, it's tremendous value, and it's also very important, just from the documentation perspective, making sure that all the information is there for care. It's not just a insurance issue, obviously, so that's really critically important. Super work. Thank you.
Thank you for having me.
We are at the end of our time. Any other questions or comments or any other old business, new business? There being none, adjourn. Thank you.
Thank you.
Thank you.
This meeting is no longer being recorded.